Then we go on to Dr. Nitin. He's going to talk to us on a very, very important, complicated topic. Actually, it's a management of a hard cataract. At the same time, it's a subluxated cataract. So you have in double trouble in this, just like small pupils and hard cataracts. And none other than Dr. Nitin can do justice for this topic.
Thank you, Dr. Mohan Rajan. Right at the outset, I would like to thank AIOS for this lovely course which they have had here. And thanks to Dr. Sujata for having invited me to be a part of this course. I have no financial interest. Now, in any subluxated cataract, it's important to understand the degree of subluxation. So you could have a mild subluxation, which is about 25 up to 25%, where the lens edge covers the uncovers the dilated pupil. 25 to 50% in cases of a moderate subluxation, and in case of severe subluxation, the lens edge covers more than 50% of the dilated pupil. Again, like in all complicated cases or all simple cases, a thorough clinical examination is very important. One needs to know the history of whether it's a pediatric case, whether the patient has got signs of Marfan's. Again, one needs to assess the degree of zonular loss. So the zonular loss could be due to focal trauma or congenital defects. It could be an extensive zonular loss in cases of Marfan and pseudoexfoliation. And it's important again to mention here that one needs to see the edge of the lens which has been subluxated. So if it is a flat edge, it just means that the remaining zonular fibers would be strong and healthy, as opposed to a round edge where the adjacent zonular fibers may not have sufficient strength. Preoperative signs of zonular loss one should know in the form of phacodonesis, iridodonesis, or maybe even having vitreous prolapse in the anterior chamber and raised intraocular pressures. In intraoperative signs of zonular loss, the first and the foremost thing one would note are the radial folds while puncturing the anterior capsule during capsular excess. Again, the difficulty in rotating the nucleus is a very, very important sign. Even after a thorough hydrodissection, we'll find that the nucleus doesn't rotate so easily. One should not force the rotation in these cases, because if you try and force the rotation in these cases, you could further cause the zonular dialysis. Again, there could be vitreous prolapse, which is already existing in the AC. So again, that could be due to the zonular dialysis. Now, coming to the capsular excess in cases of a subluxated cataract, the capsular excess is usually difficult because there is a loss of countertraction. You can do a capsular excess with a cystitome, or you need sometimes to use two 30-number needles to use a cross-sword capsule pinch technique. Trypan blue used in these cases is very important. It helps basically to reduce the elasticity of these tough capsules, aids in visualization. However, it's important to point out that the trypan blue can go behind the lens and therefore cause a lack of visualization of the red reflex. And therefore, it's ideal in these cases to paint the anterior capsule with trypan blue under the cover of a viscoelastic. Now, one can, in order to stabilize the bag during capsular excess in cases of large zonular dialysis, one can use capsular hooks, or one can use any instrument like a Krugen's hook to support the capsule. At the same time, it's important to center the rhexis not on the pupil, but to center the rhexis on the lens. Again, sometimes we may have to make an irregular rhexis, like an oval or a D-shaped rhexis, because you need to keep a 2 millimeter gap at least between the equator and the capsular rhexis margin. Flax can be used in mild to moderate subluxation, whereas in severe subluxation, this should be avoided. It is important that the bag be stabilized during phacoemulsification. For a moderate zonular loss, you can use capsular hooks or an anchor, whatever one is comfortable with, or one can use a CTR. The main disadvantage of a CTR is that it prevents the rotation. It makes the lens rotation difficult, and aspiration of the cortical matter also becomes difficult. So the dictum here is, place the CTR as late as you can, but as soon as you must. That is very, very important. Don't delay in keeping the CTR within the bag. In order to stabilize the bag after having the cataract out, if it is a small zonular dialysis, one can use a CTR ring less than 4 hours. From 4 to 9 clock hours, one needs to use a CTR with a CTS or a CONE combined ring. And more than 9 clock hours, one can use a scleral fixated lens or an iris claw lens. I've been using a few lenses which Dr. NITIN has so well made, which makes the scleral fixation of these lenses very, very easy. Now, in phacoemulsification, ideally in a hard cataract should be done within the bag. It prevents the likelihood of the damage to the it prevents the likelihood of the nuclear fragments going behind and but there is a lot of chances of damage to the bag or zonule, so one needs to pay particular attention to where the fragments are and where your tip is. In case of a soft dislocated or subluxated cataract, one can emulsify it into the anterior chamber. Again, cortical aspiration should be done close to the rexus margin, and you strip from the rexus margin towards the periphery in order to decrease the strain. Tangential stripping in areas of missing or weakened zonules limits the stress on the adjacent fibers. One can use either a 3-piece IOL in cases of a well-centered capsular bag. If the capsular bag is not properly stable, one can think of a scleral fixated or an iris fixated IOL. I'll now show some of these techniques in my videos. So this was a subluxated hard brown cataract, which was a traumatic cataract. And you can see it's almost about 3.5 hours of subluxation. We start off by doing a rexis here. Again, if you can note over there, the edge of the lens over here is flat. So that just goes to prove that the adjacent zonules are not weak. So one can complete this rexis even without supporting the bag, because there was no real movement of the bag which was occurring during the rexis. A good hydrodissection is very, very paramount. Having done this, one needs to initially debulk the anterior epinucleus from these cases, because unless you debulk the anterior epinucleus, it will be difficult to insert your CTR ring. Again, every time you're coming out with the phaco probe, it's very important not to suddenly come out, but to inject viscoelastic, reform the bag, and then only come out from your, lift your leg from the irrigation. We now go ahead by inserting the CTR ring. Again, this is a large eye, so we are using a 13.5 millimeter CTR ring. Inject it away from the area of the dialysis, and then dial it towards the area of the dialysis. Using a bimanual technique, 2 instruments is very important. One needs to be sure that the CTR ring has gone into the bag and one edge is not in the sulcus. And then one can go ahead with emulsifying these cataracts like in any other hard cataract, like Dr. Mohan Rajan had initially shown and Dr. NITIN also so well demonstrated. The steps remain the same. It's important to work in the center. Do not go into the periphery. Normally in these cases, I wouldn't do a tangential chop like Dr. Mohan Rajan demonstrated. A vertical chop works beautifully in these cases. One needs to be patient to chop each piece. Again, it's at times in these hard cataracts, as you keep chopping, it is better to get a few fragments out. So that what happens is you have enough space for the nucleus to rotate, because you don't want to forcibly rotate these nuclei. So as you keep chopping, it's better to get individual fragments out instead of waiting for a chop of all the fragments like we normally do in a normal case. So you see, most of the fragments are being chopped and aspirated within the bag. There a few fragments do come out, so one needs to keep filling the chamber with a good viscoelastic. And all through, the CTR has kept the bag intact. So you see that there is no movement of the bag. There is no sudden increase in the depth of the chamber to suggest that further zonules are also being damaged. So one needs to keep a close attention at the rexus margin all through during the surgery, because if you see the rexus margin suddenly coming towards the center from the opposite edge, there are high chances that you have destroyed the zonules in that area, and therefore the bag is getting subluxated even from that area. So the remaining phacoemulsification goes on, the aspiration, once all the nuclear fragments are chopped. I'll go a little bit fast. So the cortex is then removed. In these hard brown cataracts, there's hardly any cortex. Again, stripping of the cortex has to be done very, very carefully in areas of the zonular dialysis. And then a single piece IOL can be inserted in the bag. in these cases. The CTR ring has kept the bag stable, so we didn't feel the need of putting in a CTS segment over here. The wound is hydrated. This is the end of the surgery, and these are the pictures 1 day post-op. So there was a corneal opacity which was already there because it was a traumatic cataract. My next case is, it's not a hard cataract, but would like to point out a few steps. The steps would remain the same. This is a subluxated cataract with vitreous already pre-existing in the anterior chamber. So here we need to first get the vitreous out, and the ideal way would be to go from the pars plana so that you don't pull the vitreous anteriorly even more. So you're debulking the vitreous in the area of the zonular dialysis. So we're doing a 23 gauge vitrectomy only in the area of the loss of the zonules. Again, here you see that it's a large area of zonular dialysis as compared to the previous case. Started the rhexis with a cystotome, and then we're completing it with a utrata forceps. Again, since there is no counter traction at this stage, I decide to put in 2 capsular hooks. Now here, this was a soft cataract, so we're trying to, while hydrodissection, trying to get the nucleus out, and then it is very easy to emulsify this lens. And since in a very soft cataract, this could even have been aspirated, but in a hard cataract, one would need to follow the steps as shown in the previous case. And here we are aspirating out the fragments. Now, since it's a large area of zonular dialysis, we are putting in a CTR ring with a CTS segment. So that is the ring being injected with an injector. And then a CTS segment is sutured. The bag is stabilized with a scleral tunnel incision. Railroading of the sutures are being done here, so that the knot in the sclera lies in the scleral tunnel itself. Again, once you need to see the amount of tightening so that the bag is not flax, and then the anterior vitreous which is there in the chamber now is got out, and a single piece IOL is inserted into the bag. My next case is a case of a subluxated cataract in a patient with Marfan's, a young patient here. Again, not a very hard cataract, but to show a few principles. This is an area of a very large subluxation. So we start by making a Hoffman's pocket over here to stabilize the CTS segment, stabilize the bag with the CTS segment. We are starting with 4 incisions. Fill the chamber with a viscoelastic. And now we start, this is the cross-sew technique. So these are 2 30-number needles. They are used as a cross-sew technique to initiate the rhexis. And once the rhexis is initiated, you can try and complete it. Here again, while completing it, you saw that there was the movement of the whole nucleus. So we are using a Krugen's hook to act as an artificial zonule or to give counter traction in the area of the dialysis. And then you can complete the rhexis. Again, you can see the rhexis being centered on the lens itself. You can't center it on the pupil. Having completed the rhexis, one needs to do a thorough hydrodissection, because it's hydro and visco dissection, because otherwise you would not have space to insert the capsular hooks. So we are putting in 2 capsular hooks in the area of the dialysis. Just speeden that up a little bit. So the capsular hooks are inserted, and now again, being a soft cataract, we're just doing a bimanual and getting the lens matter out. It was a young patient with Marfan's. The reason why I'm showing it, in spite of the fact that it is not a hard cataract, and the course I know is of a hard cataract, the principles remain the same. So now you see that it's a well-centered bag due to the capsular hooks. So we now again put in a CTR, a CONE CTR with a CTS segment. So we are passing a suture, a 90 proline. The CTS segment is then being inserted into the bag. It's important that the segment is now rotated and brought in the area of the maximum zonular dialysis in order to give a support over there. So one needs to see that it is exactly in the area of the maximum dialysis. And now you can use the same railroading technique. Only thing is here we have not made a scleral tunnel. We made a Hoffman's pocket. So the needle would start above through the sclera transconjunctivally above the area of the Hoffman's pocket, so that at the end of the suturing one can get the sutures out. Again, it's important after having inserted the CTS segment to do a thorough vitrectomy in these cases. Again, I would prefer a pars plana vitrectomy. Here you can see these sutures being drawn out with a hook through the Hoffman's pocket so that the knot is not exposed. So that was the end of that surgery. Again, it's a difficult case in hard cataracts, but the point is it can be done. Now, my last case, I would like to show that in cases where you cannot do a phacoemulsification, it is possible to do a SICS also with a hard brown cataract. So this is a subluxated hard brown cataract. You can see the area of the subluxation in the superior quadrant. It's about 3 to 4 clock hours, rather 2 to 3 clock hours in the superior quadrant. It's important in these cases to start operating on the side, from the side of the area of the subluxation, so that the subluxated area is, you're facing the subluxated area and not on the opposite side. The steps for the SICS are the same like all of your eminent surgeons have been doing. You make a proper tunnel. A large tunnel in these cases would be better. Enter the chamber, do a rhexis. Now, having done the rhexis, the next step is to make relaxing incisions in the rhexis, because this relaxing incision is very important. We don't want to cause too much stress on the bag while trying to anteriorize the nucleus. So inject viscoelastic behind the nucleus and do a visco as well as a hydrodissection at the same time to try and dial the nucleus into the anterior chamber. Again, moment the nucleus is out, fill in the bag with more viscoelastic, because you don't want, and to check whether there is any further zonular dialysis. We are now putting in a CTR ring. Again, like I said, the CTR ring should always go from the side of the intact zonules and then rotate it towards the side where the zonules are absent. And now there was a slight extension, so we are just completing that rhexis in the area of the extension. The cortex which is in the bag is now aspirated. Again, you see that it is important that in the area of the dialysis, one has to be very careful while aspirating the cortex, otherwise you would increase the amount of the dialysis, and then you put in the lens in the bag. Again, while dialing the lens in these cases, one has to be again careful that you do not increase the dialysis. And that would be the end of the surgery. So thank you for your kind attention. So the basic thing is the steps are important. One needs to follow an algorithm. One needs to see the degree of zonular dialysis and how hard the cataract is, and follow each and every principle which is there. The principles are not only for the subluxated cataracts, but general principles of treating any hard cataract with a phacoemulsification. Thank you for your kind attention.
Very beautiful talk, Nitin. Very nicely covered, because it's a very tough topic as well. So the take-home message from Nitin is very simple and straightforward. That is, you need to have a circumferential support for the lens, and you also need to have a radial support. The circumferential support is given by the CTR. The radial support is given by the capsular hooks or the iris. Sometimes you can use iris hooks as well. Only thing is, please understand, that the capsular hooks rest on the equator and doesn't produce any stress on the capsular excess margin. Whereas iris hooks can cut the capsular excess margin. You need to be a little careful about it. So, but if you don't have access to capsular hooks, you can use iris hooks as well. In the beginning, you can have this thing and you can put the CTR a little